Welcome back to the deep dive. Okay, you've handed us the chart, and today we are really diving deep into the anterior knee extensor mechanism.
Mm-hmm.
You know, if you think about the lower extremity as a machine, this mechanism, it's like the high-tension cable system, isn't it? It gives you that massive power, but also the really fine braking control.
Absolutely. It's propulsion and precision.
And as someone, still really trying to get my head around all the complex soft tissue stuff, the anterior knee feels like a bit of a diagnostic labyrinth sometimes.
It can be.
So our guide through all this complexity, it's got to be the MRI. We're basically treating this imaging session as our essential, detailed pre-op scout.
That's exactly the right way to frame it. The extensor mechanism isn't just one thing. It's this high-performance network, right? You've got the quadriceps muscles, the big tendons, the patella sitting right in the middle, and then those retinacular restraints holding it all together.
Delicate but critical.
Precisely.
Yeah.
And functionally, it's doing two main jobs. Everyone gets the accelerator part, the knee extension.
Yeah.
But arguably, the more critical role, especially for stability, is the deceleration.
Yeah.
Controlling things when you land, squat, or jump.
Right.
So if you're planning any kind of surgery around there, an ACL, maybe a tibial tubercle osteotomy, even a primary repair,
Yeah.
getting this soft tissue map absolutely right beforehand, it's non-negotiable if you want long-term stability.
Okay, so our mission today is clear. We need to really drill down into this map. We'll start with the technical stuff, the MRI protocols that actually give us this high-fidelity picture.
The foundation.
Then we'll get into the common injury patterns we see, things like, the big catastrophic failures like a patellar dislocation, and then shift to the more chronic, grinding problems like tendinopathy.
The overused stuff.
Exactly. And finally, we have to tackle that special challenge. Imaging the knee after it's got hardware in it. The total knee arthroplasty.
Yeah, the TKA presents its own set of hurdles. But maybe let's start with an analogy just to set the scene, kind of emphasize the gravity here.
Okay.
Think of the knee like a finely tuned, high-leverage machine. Maybe a drag racer.
Huh. Okay, I like it. Powerful.
Right. The patella, it's like the central pulley in that system. It's designed perfectly to multiply and channel the massive horsepower coming from the quadriceps. But here's the catch. The pulley needs a perfectly shaped track to run in. That's the trochlear groove. And it needs strong guy ropes, medially and laterally, the retinacula, to keep it dead center.
Makes sense.
Now, if that pulley slips off its track, maybe because the track's faulty or there's some sudden trauma, the sheer forces involved are enormous. The whole system can just, collapse.
Catastrophic failure.
Exactly. So we need the absolute best resolution imaging we can get. We need to see the tiny tears, the subtle bone bruises, the little alignment problems that tell us precisely how and where that system failed.
All right, so if we're building this high-fidelity roadmap, first things first, the equipment, the gear. When you're mapping soft tissues, signal quality is absolutely everything, isn't it? And the sources are pretty clear. For this kind of detailed musculoskeletal work, the days of the low-field open scanner are kind of over. We really prefer the raw power of the magnet, right? Specifically, closed 3 Tesla Systems 3T, or at least the newer, really robust 1.5T machines.
Yeah, absolutely. And look, it's not just about getting a prettier picture. It's fundamentally about contrast and resolution. That jump from, say, an older 1.5T or an open magnet to a 3T system, it's transformative.
Yeah.
And the reason is the superior signal-to-noise ratio, the SNR.
Right, the SNR. More signal, less noise.
Exactly. And that high SNR is what lets us use thinner slices and push the spatial resolution higher without the image just dissolving into noise.
Right.
When we're talking about defining really delicate fibrous things like the tiny fibers in the MPFL or the retinaculum, high resolution is the only way you can reliably tell a partial tear from just some surrounding swelling or edema.
And getting that high-res data depends critically on optimizing right at the antenna level. You mentioned the dedicated knee coil.
Oh, it's non-negotiable. Absolutely non-negotiable. That dedicated knee coil, it's a receiver antenna that fits snugly right around the knee. Its job is to maximize the capture of the signal that's emitted by the hydrogen protons in the knee tissues after we hit them with radio waves.
So it's close to the source.
Precisely. If you try and use a generic body coil, the receiver's just too far away and the signal quality drops off dramatically. It's like trying to hear a whisper from across a crowded room versus holding a microphone right up to the speaker's mouth. The better the signal we get, the clearer that soft tissue roadmap becomes.
Okay, so hardware's optimized, coils in place. Now we load up our diagnostic palette, the specific pulse sequences that actually paint the picture. Our sources really emphasize that the proton density, the PD weighted sequence, is the musculoskeletal mainstay. It's the workhorse. Why PD? Why not say T1, which gives great anatomy, or T2, which really highlights fluid?
Yeah, that's a good question. It gets into the physics of tissue contrast. So
Hmm.
T1 weighting, you're right. It's fantastic for showing gross anatomy because it differentiates fat and water really well. Fat looks bright, fluid looks dark. But for the subtle soft tissue problems, especially in tendons and cartilage, T1 just doesn't have enough internal contrast.
Okay.
And T2, while it's great for making fluid popple, it looks bright white. It often makes the whole image a bit too bright, especially with fat suppression. That brightness can actually obscure some of the finer anatomical details we need when we're chasing high resolution.
Mm.
PD weighting sort of hits the sweet spot.
The Goldilocks zone.
Exactly. That's a perfect way to put it. PD gives you that high resolution and superb soft tissue contrast because it's better at differentiating between tissues that have similar relaxation times. Think about the dense, organized collagen fibers in a healthy tendon versus the slightly looser, more hydrated matrix you see in early tendinopathy. PD picks that up beautifully.
And it's especially good for cartilage.
Oh, yeah. It's particularly sensitive to subtle cartilage abnormalities like fibrillation or early chondral thinning, often long before they become big, obvious defects you'd see on other sequences. But you've hit on its limitation. PD alone doesn't make acute injury or inflammation jump out at you because fluid edema, hemorrhage, doesn't look dramatically different from surrounding tissue.
Which means we absolutely have to pair it with fluid sensitivity. We need sequences that use fat suppression to make the pathology really stand out. Edema, blood, joint fluid. We need those signs of injury to light up, basically scream, "Injury here," against a dark, suppressed fat background.
Correct. It's all about contrast. When you null out or suppress the bright signal from fat, any area with high water content like fluid immediately stands out. It becomes hyperintense or bright. This is essential for spotting things like bone bruises, deep muscle edema, subtle ligament tears, or bursitis. And while there are several ways to achieve fat suppression, we often rely on specialized sequences like STR, which stands for short tau inversion recovery.
STR is interesting. It sometimes takes a bit longer to acquire, but it's often the go-to when there might be small bits of metal around, right? Like suture anchors or staples.
It's a fantastic clinical tool for precisely that reason. STOR is inherently very sensitive to fluid, but it achieves its fat suppression in a way that's less affected by the local magnetic field distortions, the susceptibility artifacts that even tiny amounts of metal can cause.
How does it do that? It's not using the frequency-selective pulses like other fat-sat techniques.
Exactly. Instead of targeting the specific resonant frequency of fat protons, STOR uses an inversion pulse and carefully times the data acquisition to catch the fat signal right when it's passing through zero. It nulls the fat signal based on its T1 relaxation time. This makes it much more robust, less prone to failure in areas where the magnetic field isn't perfectly uniform, like around metal.
That brings us neatly to the big elephant in the room, the implanted knee. Imaging after a total knee arthroplasty, a TKA. Especially in older patients, the sheer bulk of those cobalt, chrome, or titanium components can create this huge, devastating black hole of artifact right where we need to see the extensor mechanism, if we suspect a tendon tear right next to the implant.
It's a complete showstopper. You simply cannot diagnose a rare but devastating complication like a quad or patellar tendon rupture right next to a TKA component if the hardware artifact just wipes out the entire anatomical area.
So this is where we absolutely must use specialized metal artifact reduction techniques.
Yeah.
The literature and clinical practice points to techniques like warp VA or CMAC.
Yes, those are the acronyms you need to know. Without them, you're flying blind near the implant.
Okay, let's unpack those a bit because they sound quite high-tech. How do they actually let us see through that metal artifact?
Right, so the fundamental problem is that the metal drastically distorts the local magnetic field. That distortion causes signals to pile up or get misplaced, creating that black void and bright edge artifact, the susceptibility artifact. Warp VA stands for view angle tilting, combined with adjustments to bandwidth. It tries to compensate for the frequency shifts caused by the metal. Imagine the artifact as a shadow. V8 essentially tries to tilt the view electronically by manipulating the frequency and phase encoding gradients during data acquisition.
So it's clever gradient work to basically look around the distortion.
In a way, yes. It helps resolve the signal in areas of high frequency shift near the metal edge, reducing the size of that black hole and sharpening the image. CNC slice encoding metal artifact correction takes a different but often complementary approach. It adds extra encoding steps within the slice selection process itself.
Extra steps within the slice.
Yeah, This gives the scanner much more information about exactly where the signal is coming from along the slice direction, allowing it to correct for the through-plane distortions that the metal causes. Think of it as getting a more accurate 3D map of the signal despite the metal interference. By using these advanced techniques, often together, we can get diagnostic quality images right up to the metal soft tissue interface. And as figure 12.220 demonstrates, this is absolutely crucial for seeing things like post-TKA tendon integrity.
That's a huge leap, technically. Okay, shifting from the tech to the anatomy itself, let's quickly refresh on the extensor mechanism as a whole. It's easy to just think quads and patellar tendon, but it's really this integrated network built for huge loads.
Absolutely. Proximally, you've got the massive force generators, the foreheads of the quadriceps femoris muscle. You have the rectus femoris, which is unique because it crosses both the hip and the knee, and then the three vasti lateralis, intermedius, and medialis. And the vastus medialis has that really important distal oblique component, the VMO.
Right, the VMO is key for patellar tracking.
Critically important. All four muscle bellies converge distally to form the incredibly strong quadriceps tendon. This tendon essentially envelops the patella as it inserts onto its superior pole. The patella itself acts as a sesamoid bone sitting within the tendon, and its job is to increase the lever arm, the mechanical advantage of the quadriceps.
And then the force transfer continues below the patella.
Yes. The tendinous fibers continue over the front surface of the patella and coalesce again to form the patellar tendon. This then runs down to insert, usually in a broad, fan-like shape, onto the tibial tubercle.
And holding the central tract stable are the retinacula.
Exactly. You have these fibrous sheets, the medial and lateral retinacula, acting like guide wires. And within the medial retinaculum, the single most important discrete structure for resisting lateral displacement, especially in early flexion, is the medial patellofemoral ligament, the MPFL.
Okay, so functionally, as we said, extension when the leg's off the ground, but maybe more importantly, stabilization and deceleration during weight-bearing activities.
That's the high-demand job, controlling the landing, controlling the squat.
And just before we dive into the injuries, a quick practical note on workflow. We're talking high-res imaging, specialized sequences. Does this take forever?
Thankfully, no, not anymore. With modern scanners, especially a 3T, and using those dedicated coils and efficient techniques like parallel imaging, you get a really comprehensive high-resolution knee MR exam done surprisingly quickly. The sources mention under 15 minutes on a 3T, maybe under 20 on a good 1.5T.
That's great. It respects patient flow and comfort.
Absolutely. Quality and efficiency aren't mutually exclusive here if you optimize the setup. We need the detailed data, but we can get it reasonably fast.
Okay, let's shift gears now to the acute catastrophic failure scenario, the lateral patellar dislocation, or LPD. This is often a non-contact injury, isn't it? And the mechanism sounds pretty brutal, that sort of rotational whiplash.
It is brutal. It's a complex, high-energy event, usually. The classic story is a non-contact injury, where the femur forcefully rotates internally, while the lower leg, the tibia, is planted and the knee is slightly bent.
So a twisting force.
A massive, sudden twisting force that creates this enormous lateral pull on the patella. And because the knee is only slightly flexed, the patella hasn't fully seated into the bony constraint of the trochlear groove yet. So the entire lateral force suddenly hits the passive restraints, especially that medial retinacular complex, including the MPFL.
And it just gives way.
It tears.
Oh.
Less often, it can be a direct blow to the medial side of the knee, pushing the patella out laterally, but that rotational torque mechanism is far more common.
And as the patella jumps laterally, it goes over the edge of the lateral femoral condyle, right? That shear force must cause damage.
Exactly. That's the first hit. As it slides over that bony ridge, the shear forces can slice off cartilage or even a piece of bone and cartilage, an osteochondral injury, typically from the median ridge of the patella or the articular surface of the lateral femoral trochlea.
But you highlighted earlier that the relocation is a second distinct injury event.
Yes, this is critical to understand. It's a double whammy. The patella gets ripped out laterally. That's the primary shear injury. But then, often spontaneously, it snaps back into place. As it relocates, the inferior medial facet of the patella crashes back down onto the lateral femoral condyle.
An impaction.
A significant impaction injury. This leaves a characteristic bone bruise or even a chondral or osteochondral defect, specifically at that inferior medial patellar facet. Recognizing both the shear and the impaction sites is key to diagnosing LPD on imaging.
This detail about the relocation injury seems incredibly important, especially because it leads right into that astonishing statistic from the sources. LPD can be clinically unsuspected in up to 73% of cases.
Yeah, let that sink in. nearly 3/4 of the time.
Why? Because it relocates so fast.
Exactly. The patient often feels a pop, intense pain, the knee swells up massively, but by the time they get to the ER or the clinic, the patella might be sitting right back where it belongs. So without a clear history of seeing it dislocated or obvious deformity, it's easy to just diagnose a knee sprain or maybe a ligament injury.
So the clinical exam can be misleading.
Hugely misleading. And that 73% figure, that, for me, is probably the single most compelling reason why early, high-quality imaging is essential for acute traumatic knee effusions. If we rely only on the history and physical exam, we're potentially missing the true diagnosis in the vast majority of these patients.
And the consequences of missing it.
They get treated conservatively for a sprain, they might do some rehab, but the underlying instability, the torn MPFL, the chondral damage, it's all still there. So they inevitably come back months or years later with recurrent dislocations, by which time they've often ground away significant cartilage, leading to premature arthritis. The MRI is our chance to catch the crime scene evidence right after it happens, even if the culprit, the patella, has already returned home.
Okay, so let's talk initial workup. Plain x-rays. Often they just show non-specific stuff, right? Big effusion, maybe some soft tissue swelling, perhaps a hint of lateral subluxation.
That's typical, but you have to look closely for the specific clues. The most important one is the sliver sign.
The sliver sign.
Yeah, it's seeing a small displaced osteochondral fragment floating around in the joint, especially when combined with a large effusion. That little sliver of bone or cartilage is the smoking gun. It's evidence that a significant shear force has occurred, strongly suggesting a recent LPD.
And what about looking at the medial side of the patella on x-ray, like in figure 12.1c?
Yes, on tangential or sunrise views, you might see a tiny avulsion fracture off the medial edge of the patella, or sometimes just some calcification or ossification there. That represents the MPFL or medial retinaculum being violently pulled off the bone. It's another strong indicator of either an acute LPD or a history of significant past subluxations.
All right, now let's get to the MRI pathology roadmap, pulling together the bone and soft tissue evidence. The bone contusion pattern, that's the undeniable proof of the impact, isn't it?
It's almost pathognomonic. It's the MRI equivalent of skid marks and broken glass at a crash site. We look for that high signal intensity within the bone marrow on fluid-sensitive sequences like STIR or fat-suppressed PD. This signal represents microtrabecular fractures, bleeding, and edema.
And the location is key.
The location tells the story. The characteristic impact sites for LPD are the anterolateral aspect of a lateral femoral condyle, specifically the non-articular surface where the patella first hits as it goes out, and the medial facet of the patella, usually the inferior part, where it impacts upon relocation. Seeing this specific kissing contusion pattern, as illustrated beautifully in figures 12.1 and 12.2, essentially clinches the diagnosis of LPD. It bypasses almost the entire differential.
Okay, bone bruises mapped. Now the soft tissue restraints. The medial patellofemoral ligament, the MPFL, and the VMO muscle, they're the critical medial stabilizers, especially in those early degrees of flexion before the bony trochlea takes over. And the MPFL gets injured almost every time, right?
Pretty much always. Estimates are around 97% of acute LPDs involve an MPFL tear. It's a primary passive tether resisting that lateral movement. And MRI is really powerful here. The sensitivity is quoted around 85%, accuracy around 80% for detecting MPFL injury.
But here's that interesting point you mentioned earlier from reference 7. MRI is reportedly more effective than arthroscopy at detecting injuries specifically at the femoral insertion. That seems counterintuitive.
It does, doesn't it? You'd think seeing it directly with a scope would be better, but it likely comes down to the anatomy and visualization challenges arthroscopically. The femoral attachment site of the MPFL is tucked away near the adductor tubercle. And in an acute setting with lots of swelling and maybe some bleeding, getting a really clear view of the insertion point itself can be surprisingly difficult.
So the scope might miss subtle stripping or interstitial damage.
Exactly. Whereas the MRI, particularly with fluid-sensitive sequences, excels at showing the secondary signs of injury right at that insertion, the surrounding soft tissue edema, the fluid tracking along the torn fibers, the subtle stripping away from the bone. It gives you this panoramic, non-invasive view of the entire trauma zone, even if the ligament fibers themselves look somewhat intact superficially.
So on MRI, we're looking for that clear discontinuity if it's a full thickness tear.
Yes, a complete gap filled with fluid or hematoma. Or, for a partial tear, we'll see disruption of some fibers, thickening, irregularity, and usually that associated high signal representing edema and hemorrhage within and around the ligament. Figure 12.4 gives a good example of a partial tear appearance.
And the location of the tear really matters for surgical planning.
Absolutely critical. Is the tear right at the patellar origin? That's shown in figure 12.1. Often these can be repaired directly back to the bone. Is it at the femoral insertion, like in figures 12.2 and 12.3? These often do worse with simple repair because the biology isn't as favorable, so they frequently require a formal reconstruction using a graft. Or is it a mid-substance tear? Those can be tricky too.
And we also need to look for injury to the VMO, the vastus medialis obliquus muscle.
Yes. Don't forget the VMO. It often tears or gets stripped off its attachment near the adductor tubercle, right along with the MPFL, especially in more severe injuries. Identifying an extensive VMO injury is important because it signals a larger destabilization of the whole medial complex. You often see this best on the sagittal images. As pointed out in figure 12.2, you can see the muscle belly retracted or elevated off the bone.
Now let's talk about the cartilage toll. The numbers are just staggering. Chondral or osteochondral injuries are reported in up to 95% of LPD cases.
95%. Think about that. If the patella dislocates, it's almost guaranteed there's some cartilage damage, even if the x-rays look completely normal.
Which makes that 73% rate of clinically unsuspected LPD even more concerning. We're potentially missing significant progressive cartilage damage.
Exactly right. That's why meticulous assessment of the cartilage surfaces on MRI is paramount. We need to scrutinize those two specific patellar injury sites we discussed. First, the shear injury, often affecting the median ridge, that happens during the dislocation itself. Second, that impaction injury to the inferomedial patellar facet that occurs upon relocation.
And that inferomedial facet injury has incredible diagnostic power.
It really does.
Yeah.
Reference 24 gives us that killer statistic. Finding a concave osteochondral injury pattern, specifically on the inferomedial patellar facet, is 100% specific for LPD.
100% specific.
Meaning, if you see that characteristic scooped-out pattern of cartilage and bone damage right there, you can definitively say, this patella has dislocated and relocated, period. It doesn't matter what the patient tells you or doesn't tell you. That finding alone confirms the mechanism. It's incredibly powerful, especially in confusing cases or, frankly, in medico-legal situations.
And the damage isn't limited to the patella, right? The femur takes a hit, too.
Yes, the lateral femoral trochleus can suffer shear injury as the patella slides over it. And we also often see contusions or chondral damage on the mid-portion of the lateral femoral condyle. This condylar injury is often linked to the associated pivot shift type mechanism that can occur during the instability event itself. You can visualize these femoral injuries well on the coronal and sagittal images, like those shown in figure 12.4.
Understanding the full extent of the cartilage damage is crucial then. It dictates treatment.
Absolutely. Is it just some subtle signal change, maybe treatable non-operatively? Is it a small, stable flap? Or is it a large, displaced osteochondral fragment, a loose body rattling around in the joint? That became a time-sensitive surgical issue, often requiring urgent arthroscopy for removal or fixation. The MRI gives us that critical information.
Okay, let's shift from the acute damage to the underlying reasons why it happened in the first place, the anatomic risk factors. These are the pre-existing flaws that make a knee susceptible to dislocation, even with relatively minor trauma. And patients with recurrent instability almost always have multiple factors compounding the problem.
That's very true. It's rarely just one thing in recurrent cases. We primarily look for and measure three key biomechanical culprits on the MRI, using established standardized methods. First up is patella alta.
The high-riding patella, how do we diagnose that reliably?
We use the Insall cell-body ratio.
Yep.
It's a simple measurement, easily done on a standard sagittal MRI view, comparing the length of the patellar tendon to the length of the patella itself. A ratio greater than 1.3 is generally accepted as the threshold defining patella alta.
And biomechanically, why is a high-riding patella such a problem? What's the consequence?
It's all about engagement. The bony stability for the patella comes from it sitting snugly within the trochlear groove. If the patella rides too high, patella alta, it has to travel further down as the knee bends before it actually enters and engages that protective groove. This means that in the first 20, 30, maybe even 40 degrees of flexion, the patella is essentially free-floating, relying almost entirely on the soft tissue restraints, especially the MPFL, for stability.
So the MPFL is under increased stress early on.
Exactly. It's vulnerable. The patella is more likely to get pulled laterally and dislocate before it gets the chance to seat into the bony track. It's like having, going back to our analogy, a train pulley that hangs way too high above its stabilizing track. It's much easier for it to swing off course before it drops in.
Okay, risk factor 1, patella alta. Risk factor 2, and this one is statistically huge, present in something like 96% of instability cases, trochlear dysplasia, TD.
Yes, TD is incredibly common in patients with patellar instability. If patella ulcer means the pulley takes too long to drop into the track, trochlear dysplasia means the track itself is faulty. It's too shallow or flattened, or even worse, it's convex, like a bump instead of a groove.
So the bony constraint is just not there.
Precisely. Remember, beyond about 30 degrees of flexion, the trochlear groove is the main stabilizer. If that groove is dysplastic, it offers little or no resistance to lateral patellar translation. Historically, diagnosing TD reliably was tough, relying on perfect lateral x-rays, which are notoriously difficult to get right. But now, with cross-sectional imaging like MRI or CT, we can get objective, precise measurements. People like Furman and Caroline have established clear criteria.
Right. We need to move beyond just saying it looks shallow. What are those specific objective MRI criteria we should be measuring?
Okay, there are 4 key measurements we look for, typically on axial images, to classify and grade trochlear dysplasia. First, trochlear groove depth. A depth of less than 3 millimeters is considered abnormally shallow. Second, ventral trochlear prominence. This measures if there's an abnormal bony bump sticking out anteriorly. A prominence greater than 8 millimeters is significant, basically acting like a hurdle the patella has to jump over.
That sounds like it would definitely disrupt smooth tracking.
It does. Third is facet asymmetry. Normally, the medial and lateral trochlear facets are roughly similar in length. In dysplasia, the medial facet is often much shorter, or hypoclastic. We quantify this with a ratio of medial to lateral facet length. A ratio greater than 0.4 indicates significant asymmetry. And fourth, the lateral trochlear inclination angle. This measures the slope of the lateral facet. An angle of 11 degrees or less is considered too flat to provide adequate lateral support.
And figure 12.6 is shown as a classic example.
Exactly. Figure 12.6 perfectly illustrates several of these features. You can see the lateral trochlea is actually convex instead of concave, and there's marked facet asymmetry. Measuring these parameters isn't just academic, it's critical because severe dysplasia, especially with multiple abnormal measurements, often indicates that a simple soft tissue procedure like an MPFL reconstruction alone won't be enough. The patient might need a trochleoplasty, a surgery to physically deepen the groove.
So that level of detail really shifts the surgical planning from soft tissue to bone work.
It absolutely does. Which brings us to the third key measurement, the lateral force vector, which we quantify using the tibial tubercle trochlear groove, TTTG distance.
Okay, the TTTG. This measures how far laterally the patellar tendon insertion point, the tibial tubercle, sits relative to the bottom of the trochlear groove.
Correct. It's a measure of the overall alignment of the extensor mechanism. If the tibial tubercle is positioned too far laterally, the quadriceps muscle pull will naturally have a stronger lateral vector, constantly trying to pull the patella out of the groove. We measure this distance in millimeters, using a standardized technique overlaying axial MRI slices from the trochlear groove level down to the tibial tubercle insertion.
And is there a critical threshold for the TTTG distance?
Yes, there's a well-established clinical threshold. While some debate exists, a TTTG distance greater than 20 millimeters is generally considered significantly abnormal and is highly correlated with recurrent patellar instability.
And the surgical implication.
If the TTTG distance is over 20 millimeter, it strongly suggests that simply fixing the soft tissues, like the MPFL, is unlikely to succeed long-term because the underlying lateral pull is just too strong. These patients typically require an osteotomy surgery to cut and physically move the tibial tubercle medially, correcting the alignment and reducing that lateral force vector. If the TTTG is normal, we focus on the soft tissues and maybe trochlear shape. If it's high, we have to address the bone alignment.
So the MRI isn't just diagnosing the acute tear, it's giving us these 3 crucial measurements: Insall cell body for patella height, the trochlear morphology measurements for dysplasia, and the TTTG for alignment that collectively dictate the entire biomechanical strategy for surgical correction.
Precisely. It's the complete preoperative plan derived from the imaging.
Okay, let's pivot now. We're moving away from the acute trauma unit and heading over to the chronic athletes clinic, or maybe just the chronic knee pain clinic. We're shifting focus to those cumulative stress injuries, the ones that result in persistent anterior knee pain, things like tendinopathies and the soft tissue impingement syndromes. This feels like a much slower, more grinding kind of failure.
It often is. And anterior knee pain can be notoriously tricky because the differential diagnosis is so broad. The patient often can't pinpoint a single event. It's more of a gradual onset, usually related to repetitive overload or overuse of that whole extensor mechanism axis, the quads, the patella, the patellar tendon.
Let's start with the classic patellar tendinopathy or jumper's knee. We see this all the time in athletes involved in jumping sports, basketball, volleyball, but also runners. What's the signature look on MRI for this chronic overuse condition?
The key findings are typically twofold. First, an increase in the size of the tendon, usually some diffuse thickening, especially at its proximal end near the patella. Second, an increase in the signal intensity within the tendon substance on sequences like PD, and sometimes subtly on fluid-sensitive sequences too.
And that increased signal, it's not necessarily acute inflammation, right? That's why we call it tendinopathy, not tendinitis.
Exactly. That increased signal usually represents mucoid degeneration, microscopic tearing, and disorganized, failed attempts at healing within the tendon fibers. It's a degenerative process, not primarily inflammatory, although there can be some superimposed inflammation. And critically, the pathology tends to be most concentrated in a specific spot, the medial aspect of the deep tendon fibers, right at the inferior pole of the patella where the tendon inserts.
Why? Right there, deep and medial.
It seems to be the point of maximum tensile stress concentration. Think about landing from a jump, that eccentric load, as the quadriceps tries to control knee flexion. The forces are highest right at the bone-tendon junction, and biomechanical studies suggest the deep medial fibers bear the brunt of that stress. Figure 12.7 shows this nicely. You see that characteristic thickening and increased signal of tendinopathy, and often, like in that figure, you can see small superimposed partial tears starting right in those deep fibers.
Okay. Less common than patellar tendinopathy, but still a significant cause of pain, is quadriceps tendinopathy.
Yes, affecting the tendon above the patella. The MRI findings are similar in principle. Increased tendon size, increased internal signal indicating degeneration. But with quadriceps tendinopathy, we often see a helpful secondary sign, reactive edema or inflammation, in the adjacent quadriceps fat pad, that pad of fat sitting just deep to the distal quad tendon. Figure 12.8 highlights this associated fat pad edema.
So seeing that edema bolsters the diagnosis.
It does. It suggests the inflammatory or degenerative process in the tendon is significant enough to irritate the neighboring tissues. And it's also a good reminder at this point. Chronic tendinopathy, whether patellar or quadriceps, represents a structurally weakened tendon. Healthy, normal tendons rarely just rupture spontaneously. Failure usually occurs against a backdrop of pre-existing degeneration, or sometimes systemic factors like chronic steroid use, kidney disease, or inflammatory arthropathies that weaken the collagen structure.
That structural weakness is the perfect lead-in to the next stage. Actual tendon tears occurring in this chronic setting. Let's start proximal again, with quadriceps tendon rupture. This tends to happen more in the over 40 population, often right at the insertion onto the superior patella. You mentioned earlier the real danger here is that it can be missed clinically.
Yeah, it's surprisingly easy to miss, especially acutely. Clinical diagnosis might be missed in up to 50% of cases.
Half the time. Why?
Usually because the tear is partial, not full thickness, or because the medial and lateral retinacular are still largely intact. Those side structures can provide just enough continuity to allow the patient to perform some weak active knee extension, or at least prevent the leg from buckling completely. So they might limp into the ER, maybe even walk, but they still have a functionally devastating injury brewing. This is where MRI becomes absolutely indispensable for confirmation.
So the MRI confirms the diagnosis, shows if it's partial or full thickness, and crucially measures how far the torn end has pulled back, the retraction.
Exactly. A complete full-thickness tear is usually obvious on MRI. You'll see a clear fluid-filled gap or discontinuity in the tendon, typically right at the patellar insertion, as shown so clearly in figure 12.9. When the quad tendon snaps completely, the strong upward pull of the quadriceps muscle is disconnected from the patella. Gravity in the intact patellar tendon then pull the patella downwards,
Resulting in
patella baja, a low-riding patella. Seeing patella baja on an X-ray or MRI after acute trauma is a strong clue pointing towards a quadriceps tendon rupture. And looking ahead, figure 12.10 shows the typical post-repair appearance. The tendon often looks thickened, heterogeneous, and loses its normal layered structure due to scar tissue. Knowing this baseline is important if you ever image them again later.
Okay, flipping the script now to the patellar tendon rupture. This one is less common overall, tends to affect younger individuals, often under 40, and frequently occurs in someone with that pre-existing jumper's knee, the chronic tendinopathy.
That's the typical scenario, and the failure pattern is usually different too. The patellar tendon most commonly ruptures right at its origin from the inferior pole of the patella, as depicted in figure 12.12.
So the tear is below the patella this time, and the mechanical consequence is reversed.
Exactly reversed. Now, the patella is no longer tethered down to the tibia, so the powerful, unopposed pull of the intact quadriceps muscle yanks the patella upwards. This results in a dramatic patella alta, a high-riding patella. So it's a neat diagnostic pair. Quad rupture often leads to patella baja. Patellar tendon rupture leads to patella alta. Seeing that position change immediately tells you where the disconnection occurred.
And we have to circle back quickly to the post-arthroplasty tear situation. Even though they're rare 0.1-0.4% incidence, a tear next to a TKA is catastrophic and impossible to see without those metal artifact reduction sequences like WARC-V8 or SAMAC.
Figure 12.13 really drives this point home. It shows how clearly you can see the tendon right up to the implant when you use the right techniques. You simply cannot afford to miss this diagnosis. A failed extensor mechanism after TKA leads to profound functional loss, instability, and usually requires complex, high-risk revision surgery. We have to be able to evaluate that tendon-implant interface reliably.
Okay, moving away from the main tendons now. Let's consider the surrounding soft tissue buffer zones, the bursae and fat pads. These structures are surprisingly good at causing pain.
Oh, absolutely. Let's start with bursitis inflammation of those little fluid-filled cushioning sacs. We have several around the anterior knee. The most well-known is probably superficial prepatellar bursitis right over the kneecap. That's the classic housemaid's knee or carpet layer's knee from direct repetitive friction or pressure. Figure 12.15 shows that subcutaneous fluid collection.
But the deeper bursae, they can be trickier to diagnose clinically, right?
They can be. The deeping for patellar bursa is a key one. It sits tucked away deep to the patellar tendon, right near its insertion on the tibial tubercle. It often gets inflamed from overuse, particularly in runners or jumpers. When it fills with fluid, it takes on a very characteristic shape on sagittal MRI.
A V shape.
Exactly. Because it's kind of partitioned by a slip of the infrapatellar fat pad, the fluid distension outlines this distinct V shape, pointing downwards, as shown in figure 12.17. Seeing that specific shape helps differentiate deep infrapatellar bursitis from just non-specific fluid tracking down from the knee joint itself.
Okay, bursae covered. Now, let's talk about Hoffa's fat pad, also known as the infrapatellar fat pad, or ITF. For years, this was just considered, anatomical stuffing, but our understanding has really evolved.
Massively evolved. We now know Hoffa's fat pad is far from inert. It's a highly vascularized and crucially richly innervated structure. Specifically, it contains substance P positive nerve fibers.
And substance P is directly involved in pain transmission.
Correct. Finding those specific nerve fibers within the fat pad provides a clear anatomical and physiological basis for pain originating directly from the fat pad itself. It completely validates the clinical entity of fat pad impingement, or Hoffa's disease, as a true source of anterior knee pain.
So Hoffa's disease, this chronic fat pad impingement syndrome, it's real. It often starts with some kind of trauma, either acute or repetitive microtrauma, leading to bleeding and inflammation within the pad.
Right. That initial hemorrhage and inflammation can then lead to fibrosis and eventual enlargement of the fat pad. Once it's enlarged and less pliable, it becomes much more prone to getting pinched or impinged between the patella, the femur, and the tibia, especially during knee extension. This sets up a vicious cycle of repeated impingement, more inflammation, more pain.
And what does the acute phase look like on MRI?
In the acute or actively inflamed stage, you'll see high signal intensity within Hoffa's fat pad on fluid-sensitive sequences like T2 fat sat or STR. This represents the edema and hemorrhage. As figure 12.18 demonstrates, sometimes the fat pad can become so swollen and edematous that it exerts a significant mass effect, actually causing the overlying patellar tendon to bow forwards.
Wow. And there's a specific localized pattern of impingement that should make us think about underlying patellar tracking issues.
Yes, that's superolateral Hoffa's fat pad impingement. When you see focal edema specifically in that upper outer corner of Hoffa's fat pad, tucked up near the inferior pole of the patella laterally, it's often a sign that the patella isn't tracking correctly. It's frequently associated with those underlying risk factors we discussed for instability, things like patella alta, an increased TTTG distance, or excessive lateral patellar tilt. Figure 12.19 shows this localized edema pattern. It's like an early warning signal that the patellofemoral mechanics are off.
Okay, one last structure in this chronic pain section, the plica. These are folds in the synovial lining, basically leftover remnants from embryonic development, usually harmless, right?
Usually completely asymptomatic, just normal anatomical variants. We can have plicae in different locations, superior, medial, lateral, inferior, which is sometimes associated with the ACL. They typically appear as thin, linear, low-signal structures on MRI.
But sometimes they become problematic.
They can, especially after trauma or inflammation. If a plica becomes thickened, fibrotic, and less elastic, it can turn into a pain generator. The medial plica is the one that most commonly becomes symptomatic.
And how does it cause pain? By getting pinched.
Exactly. A thickened, stiff medial plica can snap or rub across the medial femoral condyle. Or worse, it can actually get physically interposed or trapped between the medial facet of the patella and the medial femoral trochlea during knee motion.
And that constant rubbing or pinching can cause real damage.
Oh, absolutely. That repetitive mechanical irritation can lead to focal chondromalacia cartilage wear and tear, specifically on the opposing surfaces of the medial patella and sometimes the medial trochlea as well. Figures 12.0 and 12.21 illustrate this perfectly. You see the thickened, low-signal plica acting like a windshield wiper, rubbing away the cartilage underneath. Identifying a thickened, impinging plica on MRI, especially if associated with focal cartilage loss, can confirm the diagnosis before the patient potentially undergoes arthroscopy to have it resected.
All right, let's make our final transition now. We're moving into the realm of the engineered joint, the total knee arthroplasty, the TKA. When we're imaging an implanted knee, our focus really shifts, doesn't it? It's less about finding subtle tears and more about assessing the hardware, the alignment, the positioning, the potential for mechanical failure or loosening.
That's exactly right. The goals change. Biomechanics and component positioning become paramount. And this assessment actually starts before the surgery even happens with the preoperative blueprint.
And that blueprint relies heavily on standing, full-length leg x-ray?
Yes. Obtaining long leg standing radiographs of both legs is crucial for preoperative planning. These allow us to accurately determine the patient's overall limb alignment.
Okay, we need to define the axis clearly here. There's the anatomical axis, which just follows the shaft of the bone, the intramedullary canal. But the key one for TKA planning is the mechanical axis.
Correct. The mechanical axis is a straight line drawn from the center of the femoral head down to the center of the talus in the ankle. This line represents the true path of weight transmission through the lower limb. The fundamental goal of a standard TKA is to restore a neutral mechanical axis, meaning that line should pass right through the center of the knee joint, or perhaps just slightly medial to the center.
And normally there's an angle between the anatomical and mechanical axis in the femur.
Yes, because the femoral shaft angles inwards slightly. There's normally about a 5 to 8 degree angle of valgus between the femoral anatomical axis and the overall mechanical axis. The surgical plan involves making bone cuts on the femur and tibia that are precisely perpendicular to the mechanical axis of that bone. This ensures that when the implants are placed, they sit perpendicular to the line of weight bearing, allowing for neutral load distribution across the joint.
Okay, so that's the plan. After the surgery, we move to the postoperative assessment. Radiographs are still the workhorse here for checking component position in the sagittal side view and coronal front view plans. But that overall axial alignment check on the standing X-ray is probably the most critical for long-term success.
It's arguably the single most important factor determining implant longevity. We need to confirm that the mechanical axis, often visualized using Marquez line on the long leg film, intersects the center of the prosthetic knee joint. Any significant deviation or malalignment is strongly linked to problems down the road.
What kind of problems?
Primarily, accelerated wear of the polyethylene liner, the plastic spacer between the metal components, and an increased risk of aseptic loosening, where the implant starts to debond from the bone without infection.
And the tolerances for alignment are incredibly tight, aren't they? What are we aiming for?
They are very tight because the forces across the knee are so high. Ideally, the mechanical axis should be restored to within 3 degrees of neutral. 0 degrees. However, many surgeons aim for an even tighter window, perhaps trying to achieve somewhere between 1 degree of varus, bow-legged, and 2 degrees of valgus, knock-kneed.
Why is even a few degrees off so bad?
Think about load distribution. If you leave the knee even, say, 5 degrees in varus, the vast majority of the patient's body weight gets concentrated onto the medial compartment of the polyethylene liner. That drastically increases the contact stress, leading to much faster wear and tear on that side, and potentially early failure. The opposite happens with significant valgus malalignment. You overload the lateral side. Achieving neutral alignment is all about distributing the load evenly across the implant surfaces.
Makes sense. Okay, besides overall limb alignment, the other really crucial factor for knee function after TKA is restoring the joint line JL height correctly. This seems critical for ligament balance and overall knee kinematics.
It's absolutely critical. The joint line is essentially the level at which the femur and tibia articulate. If the surgeon puts the implants in such a way that the joint line is raised or lowered too much compared to the patient's native anatomy, it messes up the tension in the collateral ligaments, the MCL and LCL, and the overall balance of the knee.
How do we measure joint line height post-operatively?
It's typically measured on the radiograph as the perpendicular distance from the articular surface of the tibial plateau component down to a reliable bony landmark, usually the tibial tubercle. The key finding from the literature is that keeping the change in joint line height compared to the pre-op state to 8 millimeters or less correlates significantly with better functional outcomes, better range of motion, better stability, higher patient satisfaction scores.
And if it's changed by more than 8 millimeter?
An alteration greater than 8 millimeter, either up or down, suggests a significant disruption of the native soft tissue tension envelope. If the joint line is too low, resected too much bone, the ligaments might be too lax, leading to instability, especially in flexion. If the joint line is too high, not enough bone resected or components too thick, the ligaments and the extensor mechanism can become too tight, leading to stiffness, pain, difficulty bending the knee, and potentially poor patellar tracking. Getting that joint line height right is essential for restoring normal-feeling kinematics.
Okay, one last anatomical variant to touch on in the context of TKA, the bipartite patella. We mentioned it earlier as usually incidental, but can it cause problems after knee replacement?
It certainly can sometimes. Remember, this is a normal variant seen in 1–2% of people, where an accessory ossification center, usually up in the superolateral corner, the type 3 location, right where the vastus lateralis tendon inserts, fails to fuse with the main body of the patella during development.
So it's basically a non-union present from childhood.
Exactly. While it's often completely asymptomatic throughout life, the stress of a TKA surgery itself, or even minor trauma afterwards, can sometimes irritate or mobilize this pre-existing non-union, turning an incidental finding into a new source of anterior knee pain.
And MRI is the key to figuring out if the bipartite fragment is actually the source of the patient's current pain versus just being an old, stable finding.
Precisely. We need to differentiate a symptomatic bipartite patella from an asymptomatic one, or from an acute fracture through that area. The key on MRI is looking for signs of inflammation or stress at the interface, the synchondrosis between the fragment and the main patella.
So we're looking for edema again.
Yes, exactly. If you see high signal intensity on fluid-sensitive sequences, like SDR or T2 FATSAT, within that fibrous gap, the synchondrosis, or within the bone marrow of the unfused fragment itself, or in the adjacent main body of the patella, as shown nicely in figure 12.22, that strongly suggests there's motion, inflammation, and stress at that site. It points to the bipartite patella being the active pain generator. Without that edema signal, it's likely just an old, stable, incidental finding. If it is symptomatic, treatment might involve immobilization or sometimes even surgical excision of that painful fragment if conservative measures fail. #outro.
Wow, okay. This has been a really comprehensive mapping expedition through the anterior knee. We've covered a huge amount of ground, from the intricate details of the extensor mechanism anatomy to the devastating consequences of acute trauma and the grinding effects of chronic overuse, all guided by the incredible detail we get from MRI. We've seen just how vital imaging is, especially for picking up those clinically occult injuries, thinking back to that 73% of LPDs that relocate spontaneously. And we learned how crucial it is to tailor our sequences using things like Warp V8 and CMAC to overcome challenges like metal artifact and diagnose those potentially catastrophic complications around implants.
Absolutely. And I think a key takeaway is that our job, especially as surgeons interpreting these images, goes beyond just identifying a tear or some edema. We really have to synthesize all the findings. We see the high-riding patella, patella alta. We measure the faulty track, trochlear dysplasia. We quantify the lateral pull, the TTTG distance. We need to put all those pieces together to build a coherent biomechanical narrative for why this knee is unstable.
Right, because that narrative dictates the treatment.
Exactly. That synthesized understanding is what tells us whether this patient needs a simple soft tissue repair, or if we need to fundamentally change the bony architecture with an osteotomy or a trochleoplasty to give them a chance at long-term stability. That knowledge, properly understood and applied, is what makes the imaging truly valuable.
Looking back at the sheer frequency of cartilage damage, particularly after LPD, it's quite sobering.
It is. When you consider that chondral injuries happen in Up to 95% of lateral patellar dislocations.
Hmm.
95%. And then you combine that with the fact that we can see specific imaging signs like that concave inferomedial osteochondral impaction fracture pattern
Yeah.
that are 100% specific for LPD having occurred. Well, it really leads to a potentially provocative question, doesn't it? A question for you, the learner, to really mull over. How much earlier could we intervene? Maybe more aggressively, perhaps with early stabilization surgery. What if we routinely obtained an MRI on every significant acute traumatic knee effusion, especially in younger patients? Could we catch these structurally doomed knees right at the first event, before they suffer years of recurrent instability, before they accumulate irreversible cartilage damage, before they fail conservative therapy multiple times?
Instead of waiting for the second or third dislocation.
Exactly. What stands out most to you from this incredibly detailed map of the anterior knee we've explored today, and how much you use this level of imaging certainty, this ability to see the hidden damage and the underlying risks, to potentially change your clinical approach or your threshold for intervention? Something to think about.